AorticEmergencies fall into two groups: ruptured abdominal aortic aneurysms, or AAAs, and aortic dissections. These patients, as we all know, are potentially extremely unstable, and time is of the essence. Over the last few years, the imaging and treatment of these conditions has rapidly evolved. This means that transferring these patients to either the imaging department for diagnostic purposes or to another centre for specialist treatment is common and something you are likely to be involved in. With the advent of aortic stents, more elderly and frail patients who would not have been deemed fit for surgery in the past are now having procedures carried out successfully. This, together with centralisation of aortic surgical services, means that more and more of these patients will be admitted to a hospital near you. These transfers are time critical. That means as soon as is safely possible. Our main aim as the transferring team is to get these patients to the receiving centre before free rupture of the aorta occurs. Remember, free rupture means the patient's chances of survival are drastically reduced. Trauma patients needing aortic intervention are a special consideration. You mustn't forget the other injuries that they may have, because these might also make them unstable and need treatment once the aortic problem has been dealt with. Another important consideration in trauma patients is the treatment of pleural effusions. Before inserting a chest drain, you must discuss this with a vascular surgeon, as the decompression of a large haemothorax may precipitate further and catastrophic bleeding. However, you must drain any traumatic pneumothorax before transfer. That means you won't have to put a drain in the CT scanner or in the back of an ambulance where there's no room in an emergency situation. Believe me, that is no fun. So why do these patients die? Initially, it's usually from uncontrollable bleeding from the aortic rupture. Secondly, from myocardial infarction. Remember, these patients have significant cardiovascular disease. In the late postoperative phase, they can get multi-organ failure. When you're transferring a patient like this, what information do you need from them? You need to take an ample history. A, allergies. M, medication. P, past medical history, especially renal, neurological and cardiovascular history. L, last meal. E, events. That means what happened. This is all essential information that you will be asked at the receiving centre. Think about what you would normally ask when you receive a patient into your care. This is what you must be ready to deliver. So what physiological parameters are we aiming for during transfer? Unfortunately, there's very little evidence to guide us, so we have to use good old-fashioned common sense. What we're trying to do is minimise aortic wall stress, and by that I mean controlling the blood pressure and heart rate, but we need to keep the other organs perfused. Sometimes this is easier said than done. A good guide to organ perfusion is level of consciousness. If a patient is awake and talking to you, blood must be getting to where it needs to go. One of the central principles of the transfer training course is that full patients travel better. This is probably the one situation where that's not the case. Think of the aortic tear. The higher the blood pressure and the fuller the patient, the more likely it is to tear further. I would advise keeping the systolic blood pressure under 100 millimeters of mercury and the heart rate under 100. This is all very well, but how do you achieve that? Firstly, analgesia. Blood in the wrong place hurts, so give pain relief. For persistently raised blood pressure, consider intravenous beta blockers, nitrates, or even clonidine. Titrate small amounts to effect and don't use drugs you're not familiar with. This is always a recipe for disaster. Stick to what you know. Appropriate vascular access is an extremely important issue which you must think about before you leave on the transfer. The bottom line is you must expect and prepare for deterioration and insert lines accordingly. You need 2 large bore or 14 gauge IVs. You should also consider putting in a small cannula for antihypertensive medications. You don't want to be blocking a large cannula for this. An arterial line is an absolute must. When these patients deteriorate, they do it frighteningly fast, and an arterial line is likely to give you the first sign of this. If there's any hope of intervention, we need to know right away. A CVP line is optional. Only do it if you're slick and quick. Multilumen is best. If you do decide to put this in, then put it in the neck, as the femorals are not accessible during the surgery. The most important point is, don't delay the transfer for a CVP line. The next step is to call the ambulance. The ambulance should be there within 15 minutes. As you're leaving, always remember to take the cross-match blood with you. The receiving hospital may not be able to use it because of internal rules, but you may need it during the transfer. Just before you go, remember to ring ahead to the receiving hospital to warn them that you're just leaving. Also ask them to register a hospital number for the patient. This makes triggering of the major hemorrhage protocol and cross-matching of blood quicker. As soon as you arrive, remember to send a cross-match sample direct to the lab as soon as you can. So, now we're on our way to the receiving hospital. What do you do if the patient deteriorates in the ambulance? Firstly, stay calm, especially if the patient's awake. If you look frightened, can you imagine how the patient must feel? Then give analgesia. Remember, blood in the wrong place hurts. Give cautious fluids. Remember that aortic tear. If the worst happens and the patient has a cardiac arrest, it's likely that CPR is going to be futile, unless you're very close to a surgeon who can clamp that aorta and stop the bleeding. The key points in transferring aortic emergencies are appropriate intravenous and arterial monitoring. A central venous line is optional. Only insert it if you're slick and quick. Don't delay the transfer for this. Blood pressure and heart rate control are absolutely essential, but you must try to preserve organ function. The important question is the patient conscious? Try to limit your fluid resuscitation. Think of that aortic tear. Speed is essential. Time is of the essence. Aortic emergencies are amongst the most challenging transfers that we ever do. What I hope I've shown is that with the correct preparation and team, you're giving the patient the best possible chance of getting to the specialist care they need.